We are moving in to our morning panel. We are going to talk about reviewing the evidence, cannabis use, schizophrenia, and psychotic disorders. And again, I'm Sharon Garrett. I am a research scientist at ADAI, and I work with the SERP team. And I am so excited to be co-moderating this morning with Sarah Oakey, who manages the newly developed research program at the Washington State Liquor and Cannabis Board. Sarah's background is in clinical psychology, and she's worked with individuals across the lifespan experiencing comorbid schizophrenia, psychosis, substance use disorders, and other serious mental health conditions. So she's perfectly positioned to be doing the Q&A at the end of this. So stay tuned, you'll see more of her. And we have a very international panel today, so notice where everybody's joining us from. I'm going to introduce our first speaker. Dr. Daniel Myran is joining us from Ottawa, Canada. He's a public health and preventive medicine physician, a family physician, and a researcher. He holds a Canada Research Chair in Social Accountability at the University of Ottawa and is an assistant professor in the Department of Family Medicine. And I'm so much looking forward to the presentation. Take it away, Dr. Myran.
Are you guys able to see my slides? Let's see. I've been told I have to pause until they come up on the screen. Okay. Maybe. Okay, well, I'm very happy to be here speaking with you today. I'm going to be touching on, we're going to do a lot of policy because as many of you may be aware, Canada legalized non-medical cannabis in October of 2018. And then we're going to be specifically focusing on healthcare visits related to cannabis and the risk of schizophrenia spectrum disorders in individuals who have such visits. I'm not sure if you guys are able to see my slides. Hopefully someone from the program will let me know if that's not the case. Okay, there you go. I think they're up. So just before we dive in, I've received government funding from the Canadian Institutes of Health Research and grants, along with a non-governmental organization in Canada, and I have no other industry funding or conflicts of interest. So today we're going to talk about cannabis policy and evolution in Canada. We're going to look at some changes in healthcare visits related to cannabis use after legalization, including those for cannabis use disorders and cannabis-induced psychosis. I'm going to summarize a study that we did on the risk of schizophrenia in individuals who have visits related to cannabis use. We're also going to look at changes in the incidence of schizophrenia in Canada after legalization, and then we'll do some public health, clinical, and policy implications. So as I was talking about, so Canada legalized non-medical cannabis in 2018. We're the second country in the world to do so, the first one to create a commercial market. And the framing of how cannabis would be legalized, and this is the kind of the framework that was done. And the idea is that we were supposed to achieve what's called strict legal regulation. And this is a chart that was used, and basically, you have two spectrums of drug policy where you move from total prohibition on the left to commercialization or commercial promotion on the right. And the thought is that when you have total prohibition, you have an unregulated illicit market with a high degree of criminal justice harms and other health harms. And that if you get into the sweet spot of strict legal regulation, you can minimize those criminal justice harms and those health harms. But that if you move too much into the area of an unregulated legal market, with promotion and widespread commercial and for-profit motives, that you might see increases in use. And just the idea that we're moving towards legal regulation for cannabis, and that probably in Canada, as in many other places in high-income countries and around the world, that alcohol and tobacco are insufficiently regulated and could be more so. So this is what has been happening. So the black line is estimated total spending on cannabis in Canada over time in quarterly sales of billions of dollars. And it represents illicit, legal non-medical, and medical cannabis. And in 2014, there was liberalization of medical cannabis in Canada. In 2018, we legalized non-medical cannabis. And then starting in early 2020, there was commercialization of cannabis, which turned into a wide variety of new products coming to market and expansion of store sales. And initially, when we legalized cannabis, there was actually a shortage of dried cannabis flower on the legal market, and that resolved. And I think for me, one of the key takeaways is that although this is often represented as a policy that's meant to replace the illicit market, if you actually look at how spending is unrolled in Canada, the legal market has expanded twice as fast as the estimated illicit market has contracted. So if you look at the amount that Canadians self-report spending on cannabis right now, it's up 40% at the end of 2022 relative to the start of legalization. This will become relevant later in the presentation, but this is the evolution of legal sales and legal stores over time in Ontario. And you'll see that when we initially legalized in Ontario, the orange lines are the actual sales that are being sold, and then the blue bars are going to turn into the number of stores per 100,000 individuals. And we see that this initial period of legalization, there was only online sales, and then there was very strict controls over the number of stores, 67 for a population of 14.5 million people. And then the store cap was removed right around the time that the pandemic began, and you rapidly see the market move from being restricted into more of a commercial entity, and that legal sales go up as well. And then this is some data tracking over time changes in cannabis use in Canada. So this is from a series of different surveys that are done. They're meant to be representative of the population. Each one's using a slightly different method. They're generally capturing past 12-month use. One of them looks at past 3-month use. But the takeaway here is that all the way back from 2010, there's been a gradual trend of increasing cannabis use over time in Canada. There's room for debate about how much, and studies have examined this, about how much it accelerates or changes after legalization. But if you look in 2023, the number of adults who are reporting past year cannabis use is almost tripled relative to the number of people in 2010. And what I continue to find shocking is that 25% to 40% of people in Canada who consume cannabis consume it daily or near daily. So a very large number of individuals who actually use cannabis do it very regularly. At the same time, we've been seeing changes in the cannabis potency in North America and around the world. This is a publication from the New England Journal of Medicine where they track the THC content of cannabis using drug seizures. So that goes up from around 4% in 1995 to just under 12% in 2012. And for context, what we're currently selling legally in Canada, almost all the products are in excess of 24% THC, or of 20% THC. So this is from this is the government who operates, the Ontario Cannabis Store operates a legal retailer who sells cannabis. And if you look at the products that they're selling, 71% of all dried flower has more than 20% THC. And if you get rid of the CBD dominant strains, 93% is above 20% THC. This is the opening website of our government cannabis retailer. The first thing that they're promoting, so they have best-selling ounces, high THC content, which is greater than 24% THC, and Ontario-grown ounces. So it's a very interesting place where the dominant stuff that's selling is at THC levels that were previously just not seen on the market. So we're going to switch over to some of the studies and healthcare data. So when I talk about all these results, they come from what's called population level data. So Canada has a universal health system. It covers 97% of people who live in Canada. So we are looking at essentially the healthcare visits for everyone who's residing in Canada. So, recent migrants, some veterans, there's a couple of groups that are not part of this, but it's very representative of the population. We're going to look at every outpatient visit to a physician, emergency room visits, and hospitalizations and their causes. And we're going to specifically identify healthcare visits that are due to cannabis or related to cannabis. That's based off of diagnostic codes and the clinical judgment of the team caring for that person. And then we'll look at the diagnosis of schizophrenia. And that's done using a validated algorithm where someone says these codes, and then you go into the medical charts, and they predict schizophrenia quite well. For the first study that I'm going to highlight, we're going to look at emergency room visits and hospitalizations in Canada. And this is for overall reasons due to cannabis. So it's capturing intoxication, poisoning, psychosis, withdrawal, a wide range of different conditions. And then in a second study, we'll look specifically at cannabis-induced psychosis, and we'll contextualize this by some of those changes in the market and regulations that I outlined. So here's the first study. So you're looking at rates of emergency room visits for cannabis use, and this is any type of cannabis condition, all the way back from January of 2010 up until the end of 2021. And the overall takeaway, if you look at this pattern, and the black lines is the rate in youth aged 15 to 24, and the orange line or the blue dots is the rate in adults or individuals aged 15 plus. And we see that this is before legalization of cannabis. The first blue line is a combination of when the medical market becomes much more accessible and the federal government commits to legalizing cannabis. Then we have legalization of strict controls, and then commercialization, which overlaps with COVID. Really, the takeaway from all of this is that ignore all the policies. The rate of these visits has gone up enormously over time, very much in line with increasing cannabis potency and the number of people who are using cannabis. If you break this down statistically and even visually, things accelerated after medical cannabis legalization and the announcement that we would legalize cannabis. Stuff stops increasing during the period of legal market, but with very strict controls. And then you see an immediate jump during commercialization and COVID. We see very similar patterns for hospitalizations due to cannabis across the entire country. We did another study on that. And what I would highlight specific to us is if you look at the change over time from the pre-legal to the commercial period, and you look at it by condition, the largest increase has been for visits for cannabis-induced psychosis, and these are hospitalizations. So up 40% if you just compare the average across these periods, much more so than intoxication or poisoning or dependence, similar to withdrawal. One of the questions is, as we observe these changes over time, how much of this is related to greater willingness to disclose cannabis or greater clinical detection of cannabis? And secondly, if you look at those periods specifically during that last area of commercialization and the pandemic, is this related to a major global pandemic with large changes in society and health service delivery, or is this related to the legal market, or maybe a combination? And we'll address those in the next slides, hopefully. So here's a follow-up study that we did tracking changes in cannabis-induced psychosis. Again, these are emergency room visits. The green line shows individuals who may or may not have schizophrenia or prior treatment for a psychotic disorder in the visits over time. And the purple line shows what's called a first presentation or first episode psychosis. This is someone who has an episode of cannabis-induced psychosis and no history of schizophrenia or other psychotic disorders. Again, we see that they're increasing over time. They level out during the restricted legalization and then start increasing again during the commercial or COVID period. Now, specific to our question of, is this a reporting bias? The argument that I would make is if this is because people are more likely to disclose cannabis use or clinicians detect it, that would be very good at explaining changes immediately after legalization during a restricted market. But it isn't great at explaining a sudden change in visits 18 months after the legalizations occurred. You wouldn't imagine that someone 18 months after legalization suddenly starts becoming more willing to disclose cannabis use. So part of the overall trend is certainly changing social norms and clinical documentation, but I really do think that this is detecting increasing use in high potency products. We can split it a couple of ways too. So the purple line here, so this is again cannabis-induced psychosis. The purple line is for people who are above the minimum legal age of purchase in Ontario. They're 19 to 24, so they can access the legal market. And the green line is for youth who are aged 15 to 18. So it's actually quite reassuring, or it's good that individuals aged 15 to 18 are not having increasing visits of cannabis-induced psychosis over time. It's very concerning to me that you see a big jump in episodes of cannabis-induced psychosis in people just above the legal age who are still at very high risk of schizophrenia and can access the legal market. We similarly compared changes in cannabis-induced psychosis, which is the green line, to changes in amphetamine-induced psychoses and cocaine-induced psychoses, and found that during this commercial cannabis period, there was an increase in cannabis-induced psychosis, but no increase in cocaine-induced psychosis or amphetamine-induced psychosis. take it, you know, it's not a definitive analysis, but certainly if increases in these visits during this period are driven by pandemic stressors, you would expect that they would impact other types of drug-induced psychoses and not just be isolated to cannabis-induced psychosis. So maybe it lends credence to the idea that the legal market expansion during this period is contributing. So the takeaways that I would say from here is that overall, there's been a very large increase in visits for cannabis-induced psychosis in the past 12 years. They've gone up almost 300%. And that should be of large concern, and we're going to get into that in subsequent studies. There's been subtle changes that differ by policy period. And I think that overall, there's some data supporting that there's a commercialization and legalization contribution here, but it's very hard to tease out changing social norms and attitudes towards cannabis as drivers of how our drug policy changes as compared to how drug policy is changing use and harms. And the next, so motivated by that initial study, we wanted to understand what happens to individuals who have an episode of cannabis-induced psychosis or visit emerge for a cannabis use disorder or another type of visit. So in this study, we took every individual in Ontario. So it's a population of almost 15 million people who was aged 14 to 65. We removed anyone who'd received treatment for psychosis or schizophrenia. We captured a subset of this cohort who have a first-time visit for substance use. And then we said, how do they develop schizophrenia over time? And if we look here, so we'll start at the top, it's for substance-induced psychoses. So we have 9.7 million members of the general population, 3,500 people with a cannabis-induced psychosis, and 13,000 people with another type of drug-induced psychosis. And within 3 years of being in emerge for an episode of cannabis-induced psychosis, 26% of people will be diagnosed, will have a new diagnosis of schizophrenia, compared to 0.1% in the general population. So just if you say, you know, someone with cannabis-induced psychosis compared to a general population member of the same age and sex, 240 times the risk of schizophrenia within 3 years. And then if you start adjusting out for socioeconomic status and prior mental health and substance use care and other things that maybe explain it, it still remains very high at 85 times the risk. And then one of the things that we were interested in too is, you know, this is our what quote unquote ultra high risk population. But what happens if you're in emerge for cannabis use with intoxication or cannabis poisoning? There's no evidence of psychosis when you're in emerge, but you have some form of cannabis use disorder or harmful pattern. And there we find that there still is a quite large elevation in the risk of schizophrenia. So just under 2% of these individuals go on to develop schizophrenia within 3 years, and it's a risk around 14 times higher than the general population of the same age and sex, and 5 times with other confounders. And then we were interested in seeing how this varied by age and sex. And the takeaway from here, so this group right here is our cannabis-induced psychosis group. So males aged 14 to 24, within 3 years of an episode of cannabis-induced psychosis, 40% of them are diagnosed with schizophrenia. Double what's happening with young females. So 14 to 24, they're around 16 or 23%, all very, very high risks. This is a very high risk population. Much higher risk, you know, that people with other types of substance-induced psychoses are at high risk, not to the same degree. And then if you look at people, you know, again, a male age 19 to 24 in emerge with cannabis intoxication has almost a 5% risk of being diagnosed with schizophrenia within 3 years, which is a very high, you know, again, this is a high risk and not necessarily someone who's typically considered high risk. We're now going to track changes in the overall incidence of schizophrenia in Ontario and then nationally. So here's a study that I was part of. This is tracking changes in the incidence of non-affective psychotic disorders. And an incident this is someone who hasn't had previous care. So this is not a prevalence. This is not the number of people who have visits. This is kind of new diagnoses. And this is set in Ontario. And we see that there's a gradual increase over time. And then if you look just during the initial period after legalization, during the restricted market, there isn't really much of a change. Now, this is now national data. So this is all for all of Canada, and this is the incidence of hospitalizations for schizophrenia in Canada. And we're looking at 15 to 19-year-olds and 20 to 24-year-olds, and by male and female. And there is, so in these younger age populations, the incidence of hospitalizations for schizophrenia have been rising over this study period. There's this jump that occurs, in 2021 and 2022, which is again during the period of the COVID-19 pandemic and when the legal markets are taking off in Canada. But these are warning signs. There's no causality here. It's not necessarily the case that increasing cannabis use is changing the incidence of schizophrenia. But I think we should look at data like this with some caution and say that absolutely further study is needed, and that the thing that's happened in Canada is going to take some time to see the results. But this could be reflecting changing prevalence and use of cannabis. And as I was just highlighting, so the average time between first cannabis use and diagnosis of schizophrenia is around 6 years. So again, for people who are kind of saying legalization happened in Canada, there hasn't been this huge uptick in schizophrenia, it's probably not, cannabis is probably not causing changes. I'm saying it's too soon, and that we really need to keep monitoring for how these changes happen. And I think it's one of the key public health questions related to legalization. So some clinical implications, and you'll notice I didn't touch on the causality. The study that, the study that I was showing of saying that people with emergency room visits for cannabis-induced psychosis or drug-induced psychosis go on to develop schizophrenia. These are not causal studies. They're not settling debates about causality. We have no control over all sorts of confounders, including genetics. And that's really important context. And that's not the goal of the research. What I would say is that, apart from these are large associations and they're worth considering, they're identifying a very high risk group. It doesn't matter if the cannabis is causing them to develop schizophrenia or not. Most of them, almost half of young men, are going on to develop schizophrenia. And these are people who probably need a high degree of monitoring and potentially interventions like an early psychosis intervention program. You then have debate about what do you do with individuals with cannabis use disorders without psychosis. The fact that almost 5% of males who show up and emerge with those conditions go on to develop schizophrenia highlights a medium risk population who are very common. And with real questions about do they go into early intervention programs or what kind of services do they need. And my overall approach to this is that a precautionary approach is, I think, definitely indicated here. Where we don't need to wait on definitive evidence of causality one way or another to say that it may be worth intervening, it may be worth closer monitoring, and it may be worth counseling people who are having these episodes of psychosis to say that it's probably worth reducing or stopping use. From a policy implication, legalization with strict controls in Canada did not seem to accelerate increases in adult cannabis use and harms. And that's been borne out. But there was a very strong trend of increasing harms and use in the lead up to legalization, related to maybe medical cannabis liberalization and changing social norms, as the government said they would legalize. In contrast, I think there's a warning sign that when you commercialize cannabis markets, and that's high potency products, widespread stores, lots of retail promotion, you can see an increase in use and harms. The public health implications of legalization, the other side of this is the criminal justice side. And one of the big arguments, and I agree with this, is that reducing criminal justice involvement for young adults, particularly racialized groups in Canada and in the United States who are disproportionately impacted, there is a strong and clear public health imperative for that. But if you take a look at cannabis crime rates in Canada, they were going down. So this is arrests for cannabis possession. This is all arrests in Canada. They're going down starting in 2011. They've been decreasing, and most of the decrease actually occurs in the lead up to legalization. It accelerates after and it stays low. But I would make the argument that you don't actually need to legalize non-medical cannabis, and you certainly don't need to create a commercial market in order to get criminal justice benefits from policy reform. And if you take a look, and again, so, the argument is you do not need to sell cannabis-infused gummies, or you don't need to sell cannabis chocolate with sprinkles on it, or have products with fluorescent promotion and, appealing branding. And this is Canada's plain packaging is right here. And it's not necessarily plain packaging. I mean, you could understand how a kid seeing something with that packaging on it would be interested in getting into it, or it might appeal to a young adult or an adolescent. So I think that you can achieve many of the promised benefits of legalization through decriminalization, and you certainly don't need to commercialize, and that we need to have a more nuanced conversation that, we can have those benefits. Those benefits are worth pursuing, but that there is a risk that doesn't necessarily need to be taken through the development of commercial markets. And then my parting thought is that cannabis use and harms are high and increasing well before legalization. And we can have a debate about what legalization does and the impact of that. But the fact that they are increasing suggests a need for further interventions. In Canada, I think there's now an opportunity to think about regulations to reduce use and harms. We have no policies governing the potency of products. And there has been ongoing, some provinces have put regulations in, but there is no pricing for higher potency products. There's no restrictions on higher potency products. And there's, considerable evidence about the association with higher THC content stuff and adverse mental health. So that would be one example where there'd be a clear case for, drawing on literature, for example, from alcohol, where you have minimum unit pricing, where the content of alcohol indicates the price of it, to say we should be pricing cannabis by the THC content, or we should have restrictions on the THC content. One of the things that happened in Canada is that it was assumed that anything that existed on the illegal market should exist on the legal market. And that's an interesting decision. It's not necessarily the case that concentrated cannabis products with 80% THC need to be offered on a legal market and sold in government stores. Maybe they continue to exist on a small illicit market that people, access because the costs of getting rid of that are very high, but it doesn't necessarily need to be promoted and available for purchase. So lots of thanks to my team, and there's my email, and I have not kept track of the time, so hopefully it's been pretty reasonable. Thanks, everyone.
Fantastic. Thank you, Dr. Myran. And we will do the Q&A for all our panelists at the end. So please continue to put your questions in Poll Everywhere. And if you have a question that you'd like a specific panelist to answer, include their name in the question, and the moderator will direct it towards them. Our next speaker is Dr. Lindsey Hines. I want to welcome her from the University of Bath in the United Kingdom. Dr. Hines brings her expertise in the epidemiology of drug use with a focus on causes and consequences of cannabis use during adolescence. So welcome, Dr. Hines.
Thank you. Thanks for such a nice introduction. And also thank you so much for having me to speak today at this absolutely fascinating conference. I don't know if you can see my slides yet. Oh, I can see my name. I feel like that's a good sign that slides are coming. But as said, I'm an assistant professor at the University of Bath in the Department of Psychology, and I'm co-director of the Addiction and Mental Health group there. So my talk today, I really enjoyed Daniel's talk, and actually I feel like my talk follows on really nicely from it, because I am going to be talking a lot more about causality and the extent to which we can understand causality in the relationship between cannabis potency and psychosis and psychotic experiences. So just some context about me. I am an epidemiologist. I focus on addiction and mental health epidemiology and trying to understand the causes of both addiction and mental health and how drug use and mental health link together. I'm not a clinician, so I don't have clinical experience. I don't have lived experience of psychosis. And I'm also not industry involved and don't receive funding from the cannabis industry. The funding for most of this work came from the Wellcome Trust, which is a UK-based charity. So I'm going to try and move on the slides. Great. So as we know, to some context, cannabis is the most commonly used internationally regulated drug. And because I'll be talking about data from the UK, I wanted to give some context to the situation there, which again is very different to Canada and also different to Washington as well. So in the UK, cannabis is illegal. So we do have access to medical cannabis, but it's very difficult to access. So we have a socialised medical system, the NHS, where everyone can access treatment and care freely, and there's a very limited range of conditions which cannabis can be accessed through, and actually prescriptions have barely, it seems, been given out through the NHS. There's slightly better access through private services, but it's again a very restricted medical model. So in the UK, you still receive up to 5 years in prison for possession, a large number of years for supply, and unlimited fines. So we've got a very strong criminal framework around cannabis. There's debates around the extent to which that's applied, but that's kind of a different question. And despite all of this, or because of it, cannabis use is very prevalent amongst adolescents. So we see that up to 60% is our estimate of young people aged 16 to 24 have at least tried cannabis in their lives. So that's a situation that we're operating in. So cannabis use, of course, has very strong associations with mental health disorders, anxiety and depression, as we'll be talking about today, psychosis, and also this possible causal role in the development of psychosis. I was really struck in Daniel's talk as well about the extent that frequency of use has gone up in Canada, because we have always we've got relatively strong evidence that the risk of mental health disorders is stronger when people are using cannabis more often. So daily use would be, again, a strong risk factor for the development of psychosis and other mental health problems. And we've got concerns about the rising potency of cannabis, why we're here today, both in these regulated markets, but also in unregulated illegal markets like the UK. Police seizure data shows us that higher potency cannabis is coming to dominate over here as well. So my PhD student, Kat Petrelli, completed a large review on cannabis potency and mental health disorders with a focus as well on psychosis. And having systematically reviewed all the studies at that time, which were around on cannabis and mental health, they identified 8 different research studies which had looked at cannabis and psychosis, with multiple papers coming out of them. And there was mixed evidence, but overall the picture was of an increased risk of psychosis when people were using higher potency cannabis compared to people using lower potency cannabis. That was from both clinical and population samples, general population samples. Higher potency cannabis as well. Within this, there was indications that it was associated with an earlier onset of psychosis, more symptoms of psychosis, and in some longitudinal studies following up people who were living with psychosis, higher potency cannabis was associated with increased risk of relapse as well. But one of the key limitations we found with this was the inability to establish the direction of association. So with cannabis use and psychosis, there's always this argument that it may be reverse causation. It may be that people who start to experience symptoms of psychosis, experience deterioration in their mental health, start using cannabis potentially to self-medicate, and potentially using higher potency forms as well to try and regulate their symptoms. And that makes it, of course, very difficult to understand which way things are going. We have this within epidemiology, the catchphrase of epidemiology is correlation is not causation. So when we see 2 things occurring together, that doesn't mean that one is causing the other. And this is obviously a problem because when we're intervening on things, we really want to be targeting something that's a cause. If you stop something, if you want to, limit an outcome and the thing that you intervene on isn't actually causing it, then obviously it's going to have a limited impact on it. So we really need to start using longitudinal data and start applying more causal inference approaches to better understand causality in this relationship. So I think this is relatively obvious, the idea that you need to know if something is causal to know if intervening on it is going to have an impact. If high potency cannabis is causing psychosis, then intervening on high potency cannabis should limit that in the population. If psychotic experiences are leading to high potency cannabis use, then intervening on high potency cannabis won't make much of a difference on the kind of general population prevalence of psychosis. So I've got a probably quite flawed example here, but just to demonstrate this, if you've got a fire and you want to try and put out that fire, we know that the fire causes smoke. If you are simply trying to waft away all the smoke and see that as the cause of the fire, that's not going to help to reduce your number of fires that you're experiencing. So I feel like it's a relatively straightforward concept, but it's not well captured within the data that we've got. So I've been using a longitudinal cohort study, the Avon longitudinal study of parents and children, ALSPAC, but more catchily titled The Children of the 90s. It's based in Bristol, where I'm talking from at the moment. Bristol famed for its hot air balloons, Banksy, and also we've also got quite a high prevalence of drug use in the city as well. So this is a really amazing resource. It's a general population study, so it's not a clinical study, but in the early 90s, 91, 92, mothers who were attending maternity services were asked to take part in the study. 14,000 mothers who were pregnant were recruited into the study, and they completed surveys during their pregnancy, and then when their children were born, measures really of their children throughout their lives were taken through childhood right up to the age of 30. So we've got measures of kind of environmental exposures during pregnancy, what the mothers were doing during pregnancy. And then we've also got information on the children's social environment, their environment they're growing up in, their physical health measures and their mental health during childhood, adolescence, and into adulthood as well. People, as I say, still taking part in their 30s. So you can see that having a resource like this, where you've asked people potentially the same information over time, you've got the same people in the study, is going to be a really useful resource for understanding what comes first, what behaviours come first. If we've got behaviours measured at different time points, we can look at when they started. If they weren't happening at an earlier time point but are happening now, then we kind of know the onset of them. And also we can look at what may have preceded those behaviours happening. So that's what I've been using to try and better understand this issue of temporality, of the timing of high potency cannabis use and psychosis. So I wanted to use this data to understand whether high potency cannabis use is associated with incident psychotic experiences. And again, really handily, Daniel has defined incidence for me. So incidence being a kind of new onset of something, something that wasn't happening before, now starting. And in this case, it's psychotic experiences. Now, because it's a general population study, we have looked at psychotic experiences rather than clinical psychosis. The prevalence of psychotic disorder is relatively low, well, very low in the population. So whereas psychotic experiences are more common and more easy to pick up in a general population sample. So, sorry, this is slightly going off the page, I can see that. But at age 12, 18 and 24, psychologists came and spoke to these young people who were in the study and assessed them for hallucinations and delusions and other psychotic experiences using the measure PLIXI, so a validated measure of psychotic experiences. So we've got a measure of psychotic experiences at 3 different time points in adolescence and adulthood. At the same time, during adolescence and adulthood, we were asking these young people very regularly about their use of cannabis and how often they were using cannabis. So we've got kind of very repeated measures of cannabis use throughout adolescence as well. Now, unfortunately, because it sometimes takes a while for things to trickle through to researchers, we didn't start asking about things like the type of cannabis that people are using until they got to age 24. So that is kind of one limitation of this approach. So we were asking them at age 24, when you've been using cannabis in your whole life, like what type of cannabis have you most commonly been using? They were being asked about if they've been using herbal cannabis, skunk and what we'd call higher potency, stronger types of cannabis, and hash, resin and solid. So based on other studies within the UK, we've classified herbal cannabis and hash resin and solid as lower potency, and then skunk and other stronger types as higher potency. And again, we haven't got this high, what we're calling high potency, we think is probably about at least 10% THC. So again, different to what we're currently seeing in Canada and in modern commercial markets, but still a higher potency of cannabis. So from that, we were using this longitudinal data to try and understand whether use of higher potency cannabis was associated with onset incidence of psychotic experiences. So we had 1,560 people at this point who reported on both their cannabis use when they were teenagers and also the potency when they got to being about age 24. And as I say, we were looking at people who having not had psychotic experiences before. So we were comparing those who used higher potency cannabis with lower potency cannabis. And we did find that those who were using higher potency cannabis had twice the likelihood of having instant psychotic experiences. So compared to those using these weaker strains, lower potency strains of cannabis, those using higher potency were twice as likely to have a new psychotic experience, having not had one previously in their lives. So again, really interesting, given that this is in an illegal market and I've got some kind of, as I've said, limitations with the measure. Interesting that this kind of also fits with what the trends that Daniel is seeing as well in Canada now. We also looked at whether this was just something general to cannabis. So we compared those who were using cannabis, any of the reported types, against those who weren't using cannabis. And we didn't find this difference. We didn't find this difference in risk of instant psychotic experiences when it was just limited to any type of cannabis. So it did seem like there was something specific here about that use of high potency cannabis in increasing that risk of new onset psychotic experiences. So something else which we always have to consider in epidemiology is confounding. So this idea that other things might be causing both the exposure you're interested in and your outcome. So there might be different things which are causing cannabis use, but are also causing psychosis. And that's causing us to see a relationship between cannabis use and psychosis that isn't actually there. And again, obviously, that's very important to understand for intervention. If we're intervening on something that we think is the cause, but actually the cause was happening long ago or is in a completely different realm to what we're intervening on, then our intervention won't have much effect. So there are a number of very plausible candidates for confounding in the relationship between cannabis use and psychosis. Tobacco, so certainly in the UK, tobacco and cannabis use are intertwined. They tend to be co-administered together. And in other samples, those who are smoking cannabis tend to also be smoking tobacco. And there are relatively, there is increasing evidence for that link between tobacco and psychosis. There's also genes. So a number of the genes which have been identified as contributing to psychosis also contribute to the use of cannabis. And adversity as well. We see that people who've got adverse or traumatic experiences in their childhood are both more likely to develop psychosis and to develop cannabis use. But I think this is something really important here about the comparison group that we're looking at. As I said, we've been comparing those who are using low and high potency cannabis. So the differences here that I'm talking about in confounding would definitely be true if you're comparing people who use cannabis against people who don't use cannabis. But because we kind of, we know that these genes and adversity, exposure, tobacco prevalence and so on differ in those two groups. But when you're comparing people who do use cannabis, but just different forms, we know a lot less about what might be, potentially confounding that relationship. I actually think that when we're comparing those who use high potency cannabis and low potency cannabis, there's not really kind of a clear reason why they would have these differences in genes, in adversity, exposure, and certainly in tobacco use that we might see usually confounding that relationship. So I think that, again, when we're making these comparisons between high and low potency cannabis gives some kind of strength to this idea of causation. We've got less clear confounding in that relationship between strains of cannabis and psychosis. Needs to be better understood, of course. I think we just don't know a lot at the moment about the demographics differences in those who are using high and low potency cannabis. So I'm going to talk about some more studies that we've done, but I just want to bring up the limitations of this work whilst we're kind of thinking about it and it's fresh. There's, of course, the limitation that we're in a legal market, so we're dealing with self-reported potency. We're relying on people, in this case, people who are, in their late teens and 20s to know what kind of cannabis they're using when they're buying it from a dealer, and that might be less clear in an illegal market than it could be in markets with regulation and labeling and so on. We've also got this inferred use of potency, so where I am taking people's kind of later report of the type of potency they've used, and then using that to kind of retrospectively infer high potency cannabis. But I think, again, seeing that there's similar findings in the studies that Daniel is doing gives me kind of a bit more confidence in the methods here. If we're kind of seeing that also replicated in samples where it's not kind of being retrospectively inferred, I think that's a good sign. And also, we aren't aware of any other studies that have these longitudinal measures of psychotic experiences and cannabis use and potency. I think their psychosis is definitely generally not captured enough in these kind of longitudinal studies of the general population. I'm hoping that's something that might start being rectified as we see policy change in different countries, and we might be able to start actually getting better measures of this in other longitudinal studies in the US and Canada. And of course, we started off with 14,000 fresh new babies recruited into the study, but by the time you get to adolescence, a lot of people have dropped out. You're down to kind of 5,000 people, and the people who remain are more likely to be white, female, or more affluent than the people who were originally recruited. In terms of bias, I would actually think that might lead to us underestimating effects, because that white, female, or more affluent population are people who are less likely to be using cannabis and maybe less likely to be at risk of psychosis. So I think that suggests that the incidence rates might be a slight underestimate. So I had previously published other work from the same sample, which was included in Kat Petrelli's review, which I mentioned at the start. And so this was the first general population study of cannabis potency. Prior to this, all the studies of the relationship between cannabis use and cannabis potency and psychosis had been in clinical populations. So this was the same cohort, but I only used data from one time point. So we had cross-sectional associations, but we did have kind of longitudinal confounders. So we had this prospective data on previous psychotic experiences and so on that we're able to bring into our models. And so in this, we had just over 1,000 people who reported on the type of cannabis they'd been using at age 24 in the past year. And so we had people, again, who were using high potency cannabis and comparing them to people using lower potency cannabis. And in this cross-sectional data, again, we found that people who are using higher potency cannabis were more likely to report psychotic experiences. So this doesn't have that temporality, that timing element that the previous study did, but again, it's just a bit more evidence that high potency cannabis might be linked to psychotic experiences. But we didn't just look at psychosis as an outcome in this, we looked at other mental health outcomes, and also we looked at other cannabis use behaviours. And we found, as has been found in previous studies, that people using high potency cannabis were 4 times as likely to be using cannabis at least once a week, so to be engaging in frequent cannabis use, and 8 times as likely to report problems from cannabis use. So, and again, that was compared to people who are using lower potency forms of cannabis. So amongst people who are using cannabis, those using higher potency cannabis were more likely, much more likely to be using regularly and to have problems from their use. So there's kind of clear behavioural differences and disorder differences between those using high potency and low potency cannabis. And as I say, we did find that people using high potency cannabis were more likely to report psychotic experiences. But when we took into account the effect of frequency, the effect of using cannabis frequency, actually that relationship didn't remain. It attenuated that association. And we no longer really found an association between cannabis potency and psychotic experiences. So when I'm saying, oh, there might not be much that really confounds this relationship between potency and psychosis when we're comparing amongst people who are all using cannabis, I do wonder if frequency of use might be one of those confounding factors. As I said at the start, we know that how often people are using cannabis is something that really links to their risks of mental health conditions, including psychosis. As Daniel was saying, as I say, really interested in Daniel's talk, we've seen the frequency of use of cannabis really shoot up alongside regulation and commercialization in Canada, and alongside the increased use of cannabis, of high potency cannabis. So I think that it's worth trying to think about what actually is the relationship between frequency and potency, because it might be something that is contributing to the relationship that we see between high potency cannabis and psychosis. And it feels so when they gave us the instructions to the talk, they said, oh, don't talk too much about methods. So I feel like this has been a very methods-based talk, and this is a very methodological epidemiology point, but I think it does have some real world relevance. Because, as I say, when we're thinking about what to intervene on, we want to know what comes first. We want to intervene on something that could be actually causing the outcome that we want to prevent. So if high potency cannabis, so we've got these kind of different kind of options really for what might be happening with potency and frequency. It might be that people start using high potency cannabis and they start to develop a disorder as a result of their use, and it massively increases their frequency. They start using stronger forms of cannabis, and they start using cannabis more often as a result of that. It might be that people start using cannabis, start escalating towards disorder, start using cannabis more frequently, and develop a tolerance to the cannabis that they're using, and then progress to stronger strains, to higher potency strains. And I don't think we really understand this relationship at the moment between these two behaviors. As I say, we don't have really this kind of longitudinal data which can tell us about potency, which would allow us to kind of disentangle this. And it is, I think, important for thinking about how we're intervening and for policy as well. Because if high potency cannabis is causing people to use cannabis more often, and also it's causing people to have psychotic experiences, then regulating potency and reducing potency would be a very plausible method of reducing that instance of psychotic experience in your population. Whereas if high potency cannabis is then leading to people escalating their frequency, but it's still that frequency of cannabis use that is causing the development of psychotic experiences. Again, I also think there regulating potency is potentially one way in which you might, again, see those reductions in psychotic experience. It might be a benefit to public health. But if you've got frequent cannabis use, that's causing high potency people to use higher potency strains, but it's also causing psychotic experiences, then really intervening on potency isn't going to be the thing which reduces that prevalence and incidence of psychosis in your population. Probably what's needed there is more focus on policies that reduce the availability and frequency of cannabis in general, so that you're not seeing people escalate their use, develop a tolerance, or go on to high potency strains, whilst at the same time raising their risks for psychotic experiences. So this kind of idea comes from current thinking in causal inference, where we're thinking about the ordering of events, we're thinking about DAGs, we're thinking about kind of what we can actually see as causes and precursors of behaviors. And hopefully you can see it's not like an incredibly niche methods point, but it is something that would have utility for understanding where we can be targeting our interventions. So in conclusion, overall, I think the previous epidemiological work definitely indicates that there's a relationship between use of high potency cannabis and risk of psychosis. And even when we're considering timing in our design, we're still seeing those increased risks as well. So that is really just kind of shoring up that evidence base. And when we've even taken into account in our models, even our cross-sectional models, people's earlier life psychotic experiences as well, that hasn't really affected that relationship. So it does seem like the timing may be around higher potency use preceding the onset of psychosis. So probably overall, this does point to a rationale for policy limits on potency. We're big at the moment as well on this idea of triangulation, that you're taking evidence from different approaches. So I think this being kind of general population epidemiology, Daniel's work showing this, the kind of clinical records data and showing these population trends as well. And then the following talks, around neurobiology will be a kind of really interesting way of thinking about how are these different approaches working together, and what does kind of the overall body of evidence show. But I still think that the role of frequency is underexplored, and that understanding this might be kind of key to thinking about how we start thinking about intervention in relation to potency and psychosis. So I'd like to just thank all my study authors who've worked with me on these papers, and also my funders, of course, the Children of the 90s study and all the people who took part and who collected the data, because it wasn't me. I just get the data and analyze it. And of course, my funders as well. Thank you so much for listening, and I'm looking forward to hearing from you in the question and answer session.
Thank you so much, Dr. Hines. That was so clearly presented. As Dr. Ferguson mentioned in her opening remarks, we are going to pepper the day with some very short videos of people who've had lived experience of cannabis-induced psychosis. So before we get to our last speaker in this series, we are going to watch a short video. This is Matthew, who's a peer mentor with Johnny's Ambassadors. He's now a counselor who works with people who have substance use disorders, and he himself has personal experience with cannabis-induced psychosis.
Hello, my name is Matthew, and I would like to share my story of marijuana use and psychosis. In college, as I used marijuana to cope with feelings of depression, I began to feel more disconnected from myself and others. My marijuana use was causing my depression to spiral downward into the depths of mental despair. Little did I know, my mind was slowly starting to unravel and implode. I remember waking up one morning and feeling completely out of touch with reality. I felt as though I were an angel sent down from heaven to mend a broken planet. I called many random contacts on my cell phone to tell them how much I loved them and how sorry I was for any harm I had done. I recall walking down the street barefoot, thinking that there were secret messages hidden in the parked cars. I attempted to even break into one of these cars. When I went to my parents' house, my psychosis became heavily driven by an immense amount of paranoia that led to a fight or flight response. I walked into the kitchen of my childhood home and started tearing off paintings from the wall and throwing them on the tile floor. I remember seeing shards of glass strewn across the kitchen floor. My parents frantically attempting to hold me down and calm me. My world as I knew it was crumbling before my very eyes. My parents drove me to the nearest psychiatric inpatient facility, where I stayed for nearly 3 weeks. It was the most traumatic few weeks of my life because my mind was hijacked by a terrifying and life-changing illness. In the hospital, I remember my delusional thinking and hallucinations instilling such deep-seated fear. I remember hallucinating demons and thinking the staff were shape-shifting beasts. There was never a moment of calm, nor was there any respite from the terror my mind was generating. My mind, fueled by the marijuana use, went into full psychotic overdrive, racing a mile a minute. When I was discharged from the psychiatric unit, I was unable to fathom the support and hard work it would take to engage in my path towards mental and emotional healing. My judgment had been impaired, and as a result, I still engaged in marijuana use a handful of times after the hospital stay. I finally gave it up when I sensed the fear and paranoia returning. I attended support groups and leaned on the help and experience of others. Today, I can look back and say 10 years ago, my life was forever changed by the interaction of marijuana use and my brain chemistry. I am grateful for where I am today, working as a peer specialist and engaging in outreach to help others. Yet the road I walked down was not easy. It was and continues to be a challenging path of overcoming struggles and obstacles to maintain a healthy and positive connection with myself and others. Yet I am happy to be where I am today.
Finally, I want to welcome our last speaker in the morning's series. Dr. Deepak Cyril D'Souza is the Vikram Sodhi Professor of Psychiatry at the Yale University School of Medicine. And even though he's from Yale, he still checks our international box today because he's currently hiking the Fisherman's Trail in Portugal. And so we're going to show a pre-recording of his presentation, but he is joining us live from Portugal for the Q&A too. So we're very pleased that he was able to join and find some internet connectivity in Lisbon. Dr. D'Souza is a staff psychiatrist at VA Connecticut Healthcare System, where he's worked since 1992, and he's an active clinician, teacher, and researcher with 30 years of experience. So welcome, Dr. D'Souza.
Hi, I'm Cyril D'Souza. I'm a professor at of psychiatry at Yale University School of Medicine, and I direct the Yale Center for the Science of Cannabis and Cannabinoids. Thank you for inviting me to share my thoughts about the complex relationships between cannabis, cannabinoids, and psychosis. But before that, let me tell you that I'm not paid by any cannabis producers, retailers, or interest groups, and neither am I paid by any opponents of legalization or commercialization. So before getting into the meat of this, I want to make some important points about what psychosis is and what a psychotic disorder is. Some of this may be, some of you may know what this means, but I thought it'd be important for us to define these things before we talk about them. So psychotic symptoms of psychosis include symptoms such as hallucinations, delusions, paranoia, other perceptual alterations, ideas of reference, disorganized speech and disorganized behavior, and also catatonia. These are psychotic symptoms that might occur in isolation. And psychotic symptoms are just one domain of symptoms that constitute a chronic psychotic disorder. The other domains of symptoms include negative symptoms, which include blunted affect, amotivation, social withdrawal, anhedonia, and then cognitive symptoms, another important domain of symptoms that include impairments in attention, memory, executive function, processing speed, social cognition, and abstract reasoning. So these three domains of symptoms constitute a psychotic disorder, which the prototypical psychotic disorder that we speak about is schizophrenia. So important distinction between psychotic symptoms and a psychotic disorder. Now, I mentioned the term schizophrenia, but very, very long ago, more than 100 years ago, at that time, an influential psychiatrist proposed the idea of schizophrenias, or the group of schizophrenias. And before I get to that, I want to tell you about why it's important for us to be studying this relationship between cannabis and schizophrenia or psychotic disorders. We don't really know the cause of schizophrenia. There are many theories that have been proposed. We think genetic factors may play a role and environmental factors may play a role. And today I'm going to be speaking about cannabis. Schizophrenia costs a lot to society, both in terms of direct costs and indirect costs. And the treatments that we have for it, while good in many cases, are not so good for many patients. So I mentioned that Eugene Bleuler proposed the term schizophrenias, and I would try and explain that to you in the following way. More than 100 years ago, we thought of pneumonias as if people had symptoms such as cough, fever, fatigue, sweating, and so on and so forth. We thought of pneumonias as just one entity. And then as we learned more and more, we realized that there were pneumonias that were caused by chemicals, viruses, fungi, and there were bacterial pneumonias. And then within bacterial pneumonias, there were some that were gram positive and then others that were gram negative. I think we're probably at the same place as we were with pneumonias 50 years ago as we are with schizophrenia now. We think of schizophrenia as one unitary concept, but it's very likely as Bloiler explained many years ago, that schizophrenia is likely going to be passed out into many distinct syndromes. And I'm speculating here that one might be related to substances. So with that background in mind, I want to spend a little time talking about cannabis and cannabinoids. Of course, we know cannabis contains delta-9 THC, which is the principal psychoactive constituent of cannabis. And delta-9 THC is also available as synthetic forms and isolated forms. And more recently, there's been interest in an analog of delta-9 THC, delta-8 THC, which shares many similarities with it. And then, of course, synthetic cannabinoids, which I'll spend a moment to talking about. Back in 2008, there were a number of products that emerged on the market here in the US that were under the umbrella terms Spice and K2. These were products that had interesting names like Probation Kush and others that people were using to avoid being detected, because these products were not detectable at the time in the urine. But what these products contained were highly potent synthetic cannabinoids. And I'll spend a minute just talking about that. These synthetic cannabinoids are between 10 and 200 times more potent than delta-9 THC. And as people were using it across the state, across the US, we saw pockets of cases across the states of people becoming acutely psychotic after consuming these drugs. So this is just my way of saying that there is data emerging from synthetic cannabinoids that also support this idea of this relationship between cannabis and psychosis. So again, unfortunately, these synthetic cannabinoids are not being used as much as they were being used previously, in part because cannabis is being increasingly legalized and available in most states in the US. So as I mentioned, some of these are more than 200 times more potent than THC. So what about the relationship between cannabis, cannabinoids, and psychosis? I would argue that this relationship was recognized almost 200 years ago. This is from a book that was written by a French physician, Moreau, and this is translated from French. The title of the book is Hashish and Mental Alienation. Hashish, as you know, is the one specific form of cannabis, and he described psychotic reactions lasting but a few hours, occasionally as long as a week. The reaction was dose-related and included paranoid ideas, illusions, hallucinations, delusions, and so on and so forth. These are symptoms that we would associate with psychosis, even though this book was written at a time when the idea of the concept of schizophrenia had not yet been proposed. So this is just another way of pointing out that the relationship between cannabis and psychosis was recognized a very long time ago. Another important point for us to take away from this is that, as Moreau said, the effects were dose-related, and I'll come back to this later on. Closer to home, I'm originally from India. When the British colonized India, they convened an Indian hemp drugs commission. They formed a committee of people who investigated the idea that cannabis was associated with psychosis, given that some of the British officials had noticed an increase in the rates of psychosis associated with cannabis. And I'm just highlighting one part of the report. The moderate use of these drugs produced no mental injury. It is otherwise with excessive use. Excessive use indicates and intensifies mental instability. This report was published in 1894. And again, in this report too, what's emerging here is the idea of dose, that dose may play an important role. And when I say dose, I'm not just referring to the amount, but I'm also referring to the potency of the product, which we'll talk about later on. So I would argue that there are three distinct relationships between cannabis, cannabinoids, and psychosis outcomes. And I would organize, the way I've organized these relationships is based on the temporal relationship between exposure to these compounds and the development of psychosis outcomes. So on the far left is the idea of psychosis that emerges immediately following exposure, but resolves by the time intoxication is over. So that's relatively brief. In the middle is the onset of psychosis following exposure, but in this case, the psychosis lasts for a period longer than intoxication. The typical cannabis intoxication could last up to an hour. So here we're talking about psychosis that lasts for days and sometimes up to weeks. And then on the far right is the idea of exposure to cannabis in adolescence, followed months and sometimes years later by a chronic, persistent, recurrent psychotic disorder, which in our current nosology we call schizophrenia. So I'm going to briefly talk about the evidence supporting these three relationships. So the first, as I mentioned, is that of exposure of psychosis emerging following exposure and only falling within the period of intoxication or resolving by the time intoxication is over. This we would call an acute transient psychosis. And again, those psychotic symptoms that I'm referring to are symptoms such as hallucinations, delusions, paranoia, disorganization of speech and behavior. And then an acute persistent psychosis where the psychosis lasts well beyond the period of intoxication, shown here in yellow. And then lastly, a chronic recurrent psychosis that begins days or months or years after exposure. So what is the data to support this? There is data from experimental studies. This is data from my lab, from a study done almost 20 years ago, where we invited healthy individuals with no known risk for psychosis. And we administered different doses of THC to them versus placebo. Each subject took part in all these three conditions: placebo, low, and medium dose of THC. And we found here that THC induced a range of psychosis-like effects in healthy individuals. Well, you might ask, what kind of effects did healthy individuals report after receiving THC at different doses? And these are some of the effects. I couldn't keep track of my thoughts. Everything was happening at once. Everything was happening in staccato. My thoughts were fragmented. The past, present, and future all seemed to be happening at once. Unusual thoughts. I thought you could read my mind. That's why I didn't answer any of the questions. I felt my mind was nude. I felt I could see into the future. I thought I was God. I thought you were all trying to trick me by changing the rules of the tests to make me fail. I thought you were trying to turn the clock back on me to confuse me. I thought that this was real. I was convinced this wasn't an experiment. And one of our subjects thought we were continuing to give him THC through the blood pressure machine and the sheets of the bed. So these were fairly compelling symptoms that we would associate with psychosis. Since then, there have been many other studies, many studies from my lab and studies from other groups across the world, including groups in the UK. This is a forest plot showing showing psychosis following the administration of THC relative to placebo. And you can see the random effects model for all studies shown with this red rhombus is that the mean change is about 1 standard deviation from the norm. So it's a fairly large effect size that we are seeing with the administration of THC versus placebo in lab studies that are aimed at inducing symptoms of transient psychosis. Now, there are many, many other studies that have been done. I'm not going to bore you with all those details, other than to just summarize that in laboratory studies, we and others have shown that THC can induce the positive symptoms of schizophrenia, which are hallucinations, delusions, and so on and so forth. A number of perceptual alterations. They can also induce negative symptoms, and a range of cognitive deficits, which are also core features of schizophrenia. We also find changes on the EEG, which is an objective measure of brain function. We find deficits on the P300 amplitude. we find evidence of deficits on a task that measures the brain's capacity to generate a response when stimulated with certain frequencies like 20, 30, 40 hertz click trains. And we also find that THC induces cortical noise measured on the EEG. Now, this is just another way of saying that there's some overlap in some of the symptoms induced by THC and some of the symptoms in schizophrenia. Obviously, there's no complete overlap. Now, what about acute short-lived psychosis the duration of which extends beyond the typical period of intoxication? And some would refer to this as cannabis-induced psychosis. I believe one of the other presenters may have already presented some work on cannabis-induced psychosis. I'm just going to make a few short points about this. And I draw your attention to a study done in Denmark that was published in 2020. One of the neat things about studies done in these Scandinavian countries is that they have excellent health registries or birth registries, so they can track people from the time they're born until the time they die. And because, unlike our country, which Denmark has a nationalized healthcare system, they can look at health outcomes in their citizens. And this was a neat study that showed an increase in the rates of cannabis-induced psychosis. The rates increased by almost threefold. And this increase in the rates of cannabis-induced psychosis seemed to parallel the increased availability and potency of cannabis in Denmark. Now, there have been a couple of other studies similarly in the Scandinavian countries. One of the important things to take away from this is also some studies that were done in Denmark, Finland, which showed that individuals who had been hospitalized for cannabis-induced psychosis, if you look at what happened to them in the ensuing years, it seemed like, depending on what definition used, 50% of them were re-diagnosed with schizophrenia. What does that mean? It means that if you have an episode of psychosis, in this case, cannabis-induced psychosis, and you're seen in an emergency room, then it's very likely that that may be a sign of the later development of a chronic psychotic disorder, which in our current terminology we call schizophrenia. So that is to say, an episode of cannabis-induced psychosis may be a harbinger or may herald the development of a later chronic psychotic disorder. That's kind of worrisome. Now, what about cannabis and recurrent psychosis, or cannabis and later schizophrenia? You're probably going to hear, or you already have heard, Dr. Marta DeForti, who is going to present a lot of information on that. I'm just going to reiterate some points that she's probably made herself. And that is, if you look at all the epidemiological studies that have been done, depending on the design of the study, whether it's a cohort or cross-sectional design study, or whether it's a study defined by outcome, that is, whether you're looking at just psychotic symptoms or the diagnosis of a psychotic disorder, i.e. schizophrenia. If you put all these studies together, and there have been a number of studies that have been done over the last 40 years or so in different countries, it seems like the risk for schizophrenia or psychosis is about 4 to 6-fold higher. And I'm sure Dr. DeForti presented her own study. This is an important seminal study, a multinational study, which basically showed that your risk for psychosis, for developing psychosis, increased in a linear manner, dependent on how frequently you were using cannabis and how potent the cannabis was. So that is to say, the highest risk for developing schizophrenia was in those people who were daily users of cannabis and who used high potency cannabis. So again, this is another modern day study establishing a relationship between dose and outcome. And this is really important as we think about prevention. Now, what we do know about cannabis and later psychosis, as I mentioned, is that the frequency and amount, the potency of cannabis, the longer the duration of exposure, the earlier the exposure. So if you're exposed in early adolescence, your risk is greater than if you're exposed as a young adult. We think that childhood trauma and a family history of having a psychotic disorder or some other serious mental illness will confer a greater risk of development of psychosis or schizophrenia. But it's important to recognize that not everyone who smokes cannabis or uses cannabis develops psychosis, and not everyone with a psychotic disorder was exposed to cannabis. A similar analogy could be used about the relationship between smoking and lung cancer. Not everyone who smokes cigarettes develops lung cancer, and not everyone who has lung cancer has smoked cigarettes. But we would all agree that smoking cigarettes is an important and preventable cause of lung cancer. So cannabis is neither necessary nor sufficient for psychosis. We think it's a component cause similar to cigarette smoking and lung cancer. And we think that it may interact with other factors that we don't fully understand, but these factors could be reasonable to say that these may be genetic factors that interact with cannabis exposure, conferring a higher risk for a psychotic disorder. Now, many people will raise this issue of the chicken and the egg, and we may never ever be able to answer this question. And it would be important for us to just take into account the fact that even if we consider it's a component cause, if we can minimize the risk of the development of any new cases of psychosis by even 10 or 20%, that would have a significant impact on the mental health of our society and citizens, and would also reduce costs substantially, both to society, to families, and individuals. So I've spoken about the relationship between cannabis, cannabinoids, and the risk of developing a new psychosis. What about the effects of cannabis in people with an established psychotic disorder? So someone who already has schizophrenia, what happens when they use cannabis? We did some important experimental studies, double-blind, randomized, placebo-controlled studies where we invited people with schizophrenia to participate in a safe laboratory study where they received different doses of THC versus placebo. And we did this study because at the time the study was conceived, the only data out there was a hypothesis. There was no data, there was a hypothesis, and that hypothesis is known as a self-medication hypothesis, according to which people with schizophrenia were using cannabis to medicate their symptoms. And what symptoms were those? Symptoms such as hallucinations, delusions, paranoia, and so on and so forth. But there was not a shred of evidence to support the self-medication hypothesis. So we did an experimental study where we could definitively determine whether there was any support for the self-medication hypothesis, where we could ask patients in real time what cannabis was doing to their symptoms. And what we found is that the two different doses of THC, shown here in red and green, compared to placebo shown in blue, reliably increased, did not decrease, increased positive and negative symptoms of psychosis. That is to say, in people with schizophrenia, in double-blind, randomized, placebo-controlled studies, we find that THC increases symptoms. And this occurred in individuals who were taking antipsychotic medications. Therefore, antipsychotic medications are not protective of this. And this happened even though people were stable in their illness. So despite having clinical instability, they had an increase in psychosis symptoms. There are many other studies, both observational and laboratory studies, showing that the use of cannabis has a negative impact on the course and expression of schizophrenia. That is to say, people are hospitalized more, they end up in the ER more, they stop taking their medications more likely than not, there's less duration between frequency of hospitalizations. They end up getting into trouble with the law. They're more likely to be homeless, etc. And so we can say with confidence that there's no data to support the self-medication hypothesis. We think that the use of cannabis, which is increasing among people with serious mental illness, is going to cost individuals, families, and society more. Now, what about the effects of cannabis in people who have a risk for developing a psychotic disorder? That is to say, people who've been identified as having some greater risk. And the only two ways that we can identify people who have a greater risk of a psychotic disorder is if someone has a family member with schizophrenia, they are more likely to develop schizophrenia. And sometimes young people, adolescents, who begin to manifest soft psychotic symptoms are identified as people who might be at greater risk for developing schizophrenia. What does cannabis do in individuals who have this risk for schizophrenia? Well, this is hard to study, but there's one experimental study. And basically our impression is that people who are at clinically high risk for schizophrenia seem to be more sensitive to the effects of cannabis, and individuals with a family history of schizophrenia seem to be more vulnerable to the effects of cannabis. This was shown in a study done at Columbia University, where they invited young, healthy controls to smoke a joint, and they looked at measures of paranoia, anxiety, and euphoria or high, and they compared that to individuals who were at risk for developing schizophrenia. And you can see on the left-hand panel that individuals who were clinically high risk for developing schizophrenia had greater responses to THC on measures of paranoia and anxiety. So beyond schizophrenia, and I'm not going to spend much time talking about this, we know that cannabis is associated with addiction. We now know that the rates of cannabis addiction are rising as the potency of cannabis becomes greater and as cannabis becomes more available. We know that cannabis can cause acute cognitive deficits and has been associated with long-term cognitive deficits. There's some debate of whether those cognitive deficits resolve completely or not. And we also are seeing some data suggesting associations between cannabis use in adolescence and the development of depression and suicide and also anxiety disorders. So what might the potential mechanisms be by which cannabis induces psychosis? And that takes me back to some basics about the endocannabinoid system. So as you know, most animals and humans, not most animals, all animals and humans have an endocannabinoid system. And this is regardless of whether the animal or the human being has used cannabis or not. We know that the system includes two receptors. We know that the system involves endogenous compounds that bind to these receptors, and so on and so forth. We think that the endocannabinoid system that all of us have seem to support homeostatic mechanisms. That is to say, they serve a role in balancing the effects of other neurotransmitter systems. We think that the endocannabinoid system is important in circadian rhythm, sleep, and appetite. And no surprise, many people use cannabis to promote sleep. We know that people get the munchies when they use cannabis. So we think that that's evidence that cannabis or the endocannabinoid system is involved in sleep, appetite, and circadian rhythms. We know that especially during adolescence, the endocannabinoid system may regulate stress and anxiety. And then perhaps most relevant to the development of schizophrenia, we think that the endocannabinoid system may be involved in neurodevelopmental processes. And I'm going to talk to that in a moment. So as you know, adolescence is a critical period of brain development. That's when an important neurodevelopment process occurs, which is called pruning. So what happens during adolescence is that connections that are not necessary are removed and connections that are necessary are strengthened. So this pruning process basically prunes away unnecessary connections. And this pruning process is under the control of the endocannabinoid system. So this is just another way of showing the maturation of the brain. As you can see here, there is a significant change that occurs around teenage years that continues through adulthood. So brain maturation basically is completed by around the age of 25 or so. Now, when you look under the microscope at these neurons or these connections shown here in the middle panel, you're born with a certain number of neurons. In early adolescence, you have a lot more connections, a lot more neurons, and then there's this pruning process which cuts down the number of neurons here, and that pruning process seems to be under the control of the endocannabinoid system. Another way of showing that would be in childhood, you have many connections, and as a young adult, many of those connections are removed, which are unnecessary, and only those that are important are retained. Again, the endocannabinoid system plays an important role in regulating the pruning process. And so the endocannabinoid system, if it is perturbed by someone smoking cannabis, one could imagine how this pruning process could be messed up. And by messing up that pruning process, brain development could be disrupted, and that could lead to long-term implications that might be manifest in adulthood. So this might be one mechanism by which exposure to cannabis during adolescence might be associated with the development of serious mental illness such as schizophrenia. So as I mentioned, the endocannabinoid system could be disrupted by the use of cannabis. So I'm going to conclude there with the following points. First is that I've shown you fairly convincing data that cannabis can induce an acute transient psychosis. This has been shown in fairly well-controlled experimental studies. I can say with confidence that this relationship is causal, given that a person is fine 1 minute, not fine after they get THC and then recover. People with psychosis seem to be more vulnerable to the effects of cannabis and cannabinoids. And those with the risk of psychosis, why some people are more vulnerable than others, we don't know. And importantly, these effects appear to be dose dependent. There's mounting evidence that exposure to cannabis and cannabinoids might contribute to the development of a chronic recurrent psychosis or psychotic disorder, which we currently call schizophrenia. It seems like from some of the Scandinavian studies, an episode of cannabis-induced psychosis might herald a chronic psychotic disorder. The age of exposure and dose of exposure are important, and cannabis may precipitate or hasten psychosis in those individuals with a high risk for psychosis. And why some are more vulnerable and others is not clear, and it would be a subject of further study. So importantly, as we see more potent products emerge on the market, we shouldn't be surprised that we may see greater number of cases of new onset psychosis and also greater exacerbations of psychosis in those individuals who already have an established psychotic disorder. So what might we do to address this? First is there a way that we can delay the age of first exposure? This might be done by educating young people. The second is to limit the dose, to limit the potency of some of these products, particularly concentrates, and strengthen measures to limit access by minors. If there was a way for us to identify and educate those who are at greater risk, obviously those people with a family history of schizophrenia are at greatest risk. And then while not yet prime time, it looks like we are beginning to identify genes that might confer a greater risk for the development of psychosis. So last but not least, you may be interested in a book that extensively covers many of the topics that I've covered in these last 30 minutes. I thank you for your attention, and I'm happy to take any questions.
Wow, what a panel of international speakers. Dr. Myran, and I'm assuming we'll get the speakers up here, hopefully. Dr. Myran, your discussion on policy changes and impacts with emergency department visits and healthcare visits is so timely in the US right now, as we're seeing changes and potential future changes in local and state and federal policies around legalization. Dr. Hines, your longitudinal data set, oh my gosh, so neat. What an amazing data that you presented, and I really loved how you were visualized how difficult it is to infer causality, and how there are so many other factors that may play a role either moderating or mediating these associations. And Dr. D'Souza, I think it's super easy when we're discussing psychosis and cannabis to group everything together as one, but psychosis really is very varied. And your description of laying out that spectrum of shorter term cannabis-induced psychosis all the way to those longer term impairments, really, like schizophrenia, really elucidated that. So thank you. This panel really highlights how much research has already been done, but how much more research and more discussions are needed on this topic, and figuring out kind of next action steps on so many levels, both on the research level, on the policy level, in the prevention and public health in the clinical space, and also within the legal market itself. So with that, let's jump into questions. There's still time to enter in your questions here. We have about 20 minutes for questions. So Dr. D'Souza, I'll start with you. You were talking a lot about different types of psychosis and psychotic disorders. And kind of on the flip end with cannabis has hundreds of chemical constituents and cannabinoids. And when we're talking about psychosis, we're often referring to THC. I'm curious about what the research is with CBD, or cannabidiol, the second most common chemical constituent in cannabis, and whether you see similar associations or different associations between CBD and psychosis.
Well, thanks for that question. I think it'll be important for us to understand that the principal psychoactive constituent of cannabis is THC. CBD really doesn't produce the high or the intoxicating effects that one gets when one uses cannabis. And CBD is a very interesting molecule. I think everything that I presented so far has been about THC. CBD, first, we don't exactly know its mechanism of action, unlike THC, which works principally by binding to cannabinoid receptors in the brain to produce their psychoactive effects. THC seems to work in many, many different ways, and I don't have time to go into that. But CBD on its own, as an isolate, does not appear to be associated with psychosis. In fact, there are some studies, small studies, that need further replication. And these studies would suggest that CBD may have in fact, antipsychotic-like effects or maybe even anxiolytic effects. The important thing to keep in mind in these studies is the amount of CBD that was used in studies showing that it may have anxiolytic or antipsychotic effects is much more than one could ever get from the typical cannabis plant. The amounts of CBD are fairly low in typical herbal cannabis. So studies that have shown anxiolytic effects and antipsychotic effects used doses of CBD in the range of 800 to 1,200 milligrams, which one can't possibly get from typical cannabis. So that summarizes the effects of CBD as it relates to psychosis.
Thank you. Dr. Myran, your data showed differences between males and females. Would you be able to speak a little bit about that within your data set?
Yeah, so we did, when we've looked at changes in cannabis use disorder visits and for cannabis-induced psychosis, there are, and again, it's nuanced and depends on the policy period, but in general, there were larger increases for females than males during the commercialization period in episodes of cannabis-induced psychosis. Very hard to tease out exactly what's going on because of the overlap with the COVID-19 pandemic during that data period. But one possibility is that as more and more consumers come into a legal market, it could be that access to, you have differential access to new products and patterns of use from males and females.
Thank you. All right, Dr. Hines. There have been several questions related to not only higher versus lower potency THC products, but also the modality in which people might use cannabis, such as edibles or smoking or vaping. Do you see any differences, or what is the current state of the literature regarding different methods of use?
That's a really interesting question. And we know that, these higher potency edible products are really proliferating. And I don't think it's really understood, but I think it probably comes back a lot to what Deepak was saying about dose as well, about the kind of, higher dose that people might be receiving from edible products. So I do think certainly also, again, I work in the UK, we don't have this proliferation of edibles and so on. We're feel like we're relatively old-fashioned in that people are just smoking cannabis in joints and so on, because I think that the edibles really come along with the commercialization and this increase in products. But so I think it's less well understood, but I would expect that what we're seeing for potency would simply be exacerbated again for those edible products with that higher potency and that that greater dose which comes from ingesting.
Thank you. Yes, I do think that similar to what you're saying, research has really focused on smoked or vape because that has been the most commonly used product historically. So sounds like more research to come. Dr. D'Souza, there have been several questions coming in about potentially different chemicals or pesticides or solvents that may interact with cannabis or as it's ingested, and that may cause disproportionate risk. This is also related to how within the legal market there are hopes to create safer cannabis products. I'm curious if there is any research around that or your thoughts about pesticides and solvents that may be in cannabis products.
So it's a very good question. I don't think I know very much about the the issue of pesticides and fungicides in cannabis. But if we are talking about this in the context of psychosis, it would seem to me the single biggest driver of psychosis in cannabis is THC. If pesticides and fungicides contribute to that, and I don't know, I would expect that contribution to be fairly trivial. I think the psychosis of psychotogenic effects are really driven by THC.
Thank you. Okay, so since this really, oh yes, Dr. Hines.
Can I say something on that?
Yes, please.
Thank you. I know it wasn't my question, but I think, again, throughout my talk, I was talking about that benefit of comparing high and low potency cannabis, looking at samples of people who use cannabis. And again, I'm not aware that higher potency or lower potency cannabis would have a greater exposure to pesticides or fungicides. So I think that whilst I can understand that that is a concern for some people, again, I think that should be held relatively constant in some of the analyses where you're comparing higher, when you're comparing samples of people who use cannabis. Same as tobacco, that we'd expect that kind of exposure as well to be similar amongst people who are using cannabis.
Very interesting, thank you. Since you're on the screen and talking, I'd love to also ask you about, I know that you mentioned this in your presentation, and you have work related to adverse childhood experiences. And we know that adverse childhood experiences are large predictors of both psychosis and later cannabis use and cannabis use problems. Can you speak a little bit more about where you see adverse childhood experiences in relation to cannabis and psychosis?
Yeah, of course. So as you say, part of my work does focus on adverse childhood experiences. So we've recently published, again from the same longitudinal cohort, a study looking at the relationship between early adversity and cannabis use. We found that people who were reporting higher numbers of adversities, and this is like quite a range of things. It's from things which might be very common, like divorce, to having a parent die or be imprisoned, and including things like childhood physical and sexual abuse. So it's quite a broad category. Basically adverse childhood experiences we found were predictive of earlier onset cannabis use and more frequent cannabis use. So it's definitely something which I want to take into account more in my research as well, to consider as a confounder. And obviously we're able to do that with the children of the 90s cohort, having all that data. I have actually got work in progress, which is taking me a really long time to finish, but looking at whether cannabis use mediates the relationship between early adversity and psychosis and other mental health outcomes. So whether if we reduce cannabis use amongst people who had adversity, we might see a reduction in mental health outcomes. I don't know if I should just like spoiler my own work in a presentation, but we're not really finding that cannabis, that is a pathway through which that exposure goes. So it does seem like adversity really has its own individual effect on cannabis and also on those outcomes as well. So that's some of the work that I've been working on that. But I also do find, when I've been considering that adversity exposure as a confounder, that we do still see a unique relationship between cannabis use and psychosis as well. So I think it's a relatively complex relationship, but which I am trying to explore a bit more.
Thank you for that spoiler. Appreciate it, and I also looking forward to reading that once that comes out. I do have, there's been a lot of questions on here related to potential policy changes or really effective policy changes or interventions, either clinical or on a larger scale, of how to find individuals who are at higher risk or use policy to reduce harms. So I'll start with you, Dr. Myran. You mentioned this in your presentation. Would you be able to expand more on, in your expertise, what might be effective policy interventions?
Sure. So I think there's a couple that are really key. And the evidence base for cannabis is growing, but is still early compared to other substances like alcohol and tobacco. So I think there's a lot of parallels to be drawn there. I think that if you spread these out, there's some evidence for cannabis, lots of evidence for other substances of minimum legal ages of purchase. And I think that setting higher minimum legal ages of purchase makes sense. There's some early data from Canada showing that the higher you set it, the more protective effects there are. The States uses 21. Canada's gone to 18 in one of our provinces and 19 for most of the rest of the country. So I think setting it higher makes sense, particularly given that there's concerns about youth use and that the stronger patterns of the link between psychosis and other mental health concerns. I think that there's certainly a role for policies that reduce the use of higher potency products, and whether that is taxation or financial policies where you make the more THC content that's there is more expensive. And the market patterns in Canada has just been that it's year after year, we're selling higher and higher potency cannabis products. And with THC content, that's far beyond what's considered high risk in the literature. So I think that, financial levers to do that. I see Quebec, for example, who's the second most populous province in Canada, has taken a very different approach from much of the rest of the country for legalization. They allow no edible products to come to market. They have limits on the potency of THC. They don't allow vapes. It's a very, the sales occur through a government channel where the profits come back into tax revenue. And their experience so far has been that they have avoided some of the increases in cannabis use and harms that have occurred in other jurisdictions. I think that when we talk about legalization, it's often presented as a binary yes/no. And the reality on the ground is that it's a very complicated set of different regulatory choices. And it's boring. It's not interesting to talk. Most people are not sitting there wanting to get into the weeds of cannabis policy, but I think that there are real differences in implementation. Similarly, I think that the way cannabis ends up being marketed and promoted really matters. And again, Canada has taken an approach where there are certain types of controls over marketing and promotion. There is studies showing that they're not always being followed. Anecdotally, I would say that as time has gone on, the industry has gotten increasingly creative at potentially being within the legal fine print, but maybe violating the spirit of what the Act asked for in terms of marketing and promotion restrictions. So I think that, there's stuff to draw from alcohol and tobacco about what to do and what not to do. But I think that's another key place to intervene. And, there's of course a greater role for education. I think the track record for education and, health promotion efforts in isolation for substance use is not fantastic, and that no one who is looking at legalization, or no one who's in a situation where there isn't a legal framework for cannabis, but you're saying, oh, we'd really like to reduce the use of cannabis, should sit there and go, our job is just to educate young adults and adolescents and everything's over after that. I think that can be part of a comprehensive set of policies and packages, but you really do need to be looking at what's, the structural drivers of why individuals are using cannabis and, different regulations that can be there.
Thank you. Dr. Hines or Dr. D'Souza, I'd love for you also to weigh in on this topic of potential policy recommendations to reduce harm.
I think it has to be a multi-pronged approach. Obviously, we can take some facts from science and help us with some of these decisions. The brain only completes maturation by the age of 25, and we know that the endocannabinoid system may play a role in brain maturation. And so if there were ways to delay the use of cannabis, that would be a good thing. limiting the THC content of some of these products would be another approach to take. Education, I'm not as pessimistic about education, given that we were quite successful in convincing young people to stop smoking cigarettes. And we can take what we learned from that and apply it towards cannabis. I don't know how successful it would be on, but at the end of the day, I really don't think that this is the issue is really legalization. It's really commercialization. That's what's really happening here. And as long as there's going to be a lot of money to be made, it's going to be a real challenge in implementing strategies. And finally, if we can continue to support scientific research in identifying who's at greatest vulnerability, who's most vulnerable to develop serious mental illness from cannabis exposure, where we can really move towards tailored medicine, that would be great. Unfortunately, we're not there as yet, and we need to continue to support research to identify those who are vulnerable. But I think the previous speaker covered most of the important ways that we can try and limit. And finally, just one last thing is there needs to be some kind of national surveillance program, surveillance in terms of looking at the number of new cases of psychosis, the kind of data that our colleagues in Scandinavia and Sweden, Denmark, and Finland can get. That's what we really need, because that data will really help us guide public health policy.
Thank you so much. We have about 2 minutes. Dr. Hines, do you have anything to say on this or anything else as we wrap up?
This or anything else? This topic about regulation, I think, is interesting. I think because certainly a lot of my research focuses on youth drug use, adolescence use, and like Deepak is saying, we really want to be delaying the onset. So we know, as I say, in the UK, we've still got very high cannabis use, even though we don't have a commercial or regulated market. But I think it was interesting what Deepak was saying about smoking going down, because obviously with the rise of vaping, certainly in the UK, we're seeing vaping going up amongst young people. That seems to be to some extent rolling back a large amount of the kind of tobacco controls, because we've got a lot of products which don't have plain packaging, which are very appealing to young people. I think it's probably for trying to protect young people from cannabis use about looking at the wider market that you've got. Like Deepak and Daniel have both said, commercialization is quite a different option, is one of many policy options, and we see in those markets kind of a proliferation of advertising and so on, which might increase use amongst young people, even if you've got controls on age. I think looking at kind of the wider context of the society and the messages that are being given by the commercial sector about cannabis use, that's all going to trickle down to young people. So I think, yes, age controls are in place already, but kind of trying to make sure that it's not such an appealing prospect to young people to use cannabis is probably part of the battle to reduce harms.
Wonderful. Thank you so much, Dr. Myran, Hines, and Dr. D'Souza. I'm sure I'm not alone in saying that your presentations and your thoughtful answers are so incredibly important in this space and in this topic. So thank you so much for being here, and until next time.
So yes, huge thank you to the panelists, and also thank you to Dr. Oki for such astute facilitation. That was fantastic. I am now putting my logistics hat on again because we are at lunch hour. For those of you who are here in person, you will be able to find the lunch that you ordered on the tables kind of behind the registration desk where you came in. For those of you at home, I hope you have a PB&J or something that you can munch on this hour. And During this time in this room, we're going to loop through another lived video or lived experience video. It'll play about 4 times, so go get your lunch, mingle, come back in when you want to watch it. It's Ethan's story. He started using cannabis as a teen, and he describes how his use changed gradually and became more problematic over time.
So I got in pretty heavy into dabbing. School was a past responsibility for me. I completely just gave up on school. I somehow scraped by and graduated, and then came the summer of 2017. That was when I was free range to do whatever I want. So I dabbed and did all stupid things, would hotbox. So I'd lock myself in a car with my friend and we'd smoke it up. So like you couldn't breathe in it besides marijuana. That's something really common. And, you know, I would get high daily. I couldn't sleep without it. And it took from 1 dab to feel something. So started taking 2 or 3 to feel the same effect. You know, that standard tolerance building that you hear from. It wasn't, and this is when it started really becoming a problem because it got expensive. As you get $30 for about a couple grams of shatter, and then you go through about a gram a day. It starts, you know, you're spending hundreds of dollars a week. And of course, me and my friend stole money from my mom. We started selling our belongings. He started robbing from our friends, and we would do anything we could just to get high. And we were so oblivious to what we were doing. We still thought it was just weed. We could quit whenever we want. It's whatever. And all was good until I was sitting down on the couch. I just got done dabbing, and I hear my mom, and she yells my name at the top of her lungs. She goes, "Ethan," super loud. And none of my friends heard it. So I'm like, I get up and I'm like, oh, okay, let me go check that out. And they're all confused. And I run upstairs and she's asleep. So she never even called my name. So I was hearing her voice, and I didn't really think anything of it. I was like, well, that was odd. I could have sworn she just yelled my name, but didn't think anything of it. So I went back and smoked again. And this time I was hearing the sound of the crunching of food. So like cat food, that kind of crunching sound that they make when they eat, so oddly specific. But I was hearing that, and I had 4 cats, so I didn't think anything weird. It just kind of was like white noise. But then I look over to the food bowl, and there's no cats eating. And the sound of the food gets louder as I look at the food bowl, and it's like this crunching sound that encompasses my head. And I start kind of grabbing my head and like shaking and going crazy. And I told everybody, get out of my house, get out. They're like, what's going on? I'm like, I don't know, just get out. And at the time, my best friend Kari lived with me, and he was like, dude, you're just toking out, you're having a bad trip. So I stopped doing that, or I stopped for like a couple days for my head to clear up a little bit. And then things started to get bad again. Every time I smoked, I'd get paranoid. I'd get suspicious of Kari and about his intentions and about what he's doing. And it turns out some of those suspicions were correct, but we'll get to that. But I remember at the time, I didn't know what was going on, but I started getting obsessed with inanimate objects. I started thinking that this green towel that's hanging on my railing, that symbolizes something, and the universe is trying to tell me something. Why is this towel green? I have to get to the bottom of it. I have to figure out. So I was spending all of this whole day, then the next couple of days, like researching the color green or getting obsessed with like, why is this towel green? And very bizarre fixations. And then went from a green towel to a white lighter, and it went from just random objects, and I would obsess over them, and I would pull my hair out trying to like figure out what they all meant and how they all connected to each other. And my friend at the time was like, well, you better get to the bottom of it. And I don't think he realized he was feeding my delusion there. So I got that really, because I was like, oh my gosh, he gets it. I got to figure it out before he does, kind of thing. And that was that. And that's not even the worst part. So I continued to go back to smoking weed because I didn't put two and two together. I didn't realize that the weed was causing this because it was happening while I was sober as well. So I thought, this is just odd, but it's not the weed. And I remember feeling a snap in my brain. Like it literally felt like something like it snapped. All of a sudden, my sanity was just altered. I started hearing voices, having conversations in my head. I was having conversations with family members and friends, and I was getting in arguments with them. I was fighting with them in my head and having full-blown conversations about random topics, and it was really bizarre. And at the time, my mom kind of brushed it off as anxiety because she didn't know what was going on. I'm like, Mom, this is not anxiety. There's something going on with me. And I call that day D-Day because that was kind of the turning point. That was when my psychosis officially begun. And the very next day I had to go to work, and I go in and I worked at this factory assembly line just for a summer job, just to get some extra cash. And I'm starting to assemble these pieces, and I get these voices in my head like, you're doing it wrong, or stop doing that, you're messed, and it just bombard me with these voices in my head, and I just could not focus on work. So I went up to my boss and I quit that day, and I was like, I can't work. I don't know what's going on with me. I can't work. I can't focus. And that basically began the most terrifying couple of months of my life. So I stopped smoking. That was the first thing. So that's what was interesting, because my psychosis didn't go away for like 2 months, even when I stopped smoking weed. The worst thing for me by far was mixing dreams with reality. So it's so hard to explain when you're in a stable mind, but basically I couldn't distinguish from what was real and what I just dreamt of. There'd be moments where I'd be hanging out with my friends. I'd be like, hey, remember when we did this? And they'd be like, what are you talking about? And then I realized it was a dream I had. And that happened quite a bit. And sometimes I thought the dreams meant something. I thought, I had this really bizarre one because Kari was known for stealing stuff, stole my mom's cameras, stole all this stuff. And I'd have dreams of me finding it in particular drawers, and I'd run around the house opening those drawers when I woke up, and of course it's not there. But that was a theme was thinking the universe was telling me things. And another thing, I was super paranoid and suspicious of other people. I was shopping at King Soopers, and the receipt was printing out, and the lady next to me was kind of looking at the receipt printing out, and I snatched it really quick. And she kind of looked at me like, okay, but I thought if she took that receipt, she would have information about me. And I thought she would know, like if she took that receipt, she would know about me, whatever that meant. Like it was weird. And when I was driving home, I would always go in circles to make sure nobody was tailing me. And yeah, I lived like that for about 2 months, and it was the worst experience of my life. And to get out of it, I basically stayed abstinent, which was the main part, but I also took fish oil, started exercising, eating better. And I'm not saying it cured it, but for me, I like to think that it did help. I started seeing walk-in therapy because I knew something was wrong. That was one thing that distinguishes mine from a lot of cases is I had a lot of insight. Like I had some delusions and I had some hallucinations, but I knew something was off the entire time. I knew I was like, something's not right. I pretty much stayed abstinent for 5 years. I had a slip up about a year ago. I was kind of testing how my brain was doing. I know that sounds stupid, but I was like, if I smoke right now and I just have a good time and I feel fine, that means I've healed, right? That means that was my logic. I was like, that means I'm better. That means nothing. I'm not going to smoke all I want, but it was just kind of just out of curiosity. So I just took a little joint, couple puffs, and instantly I got paranoid. I got super suspicious, even just off of marijuana, even just off of flower now. And that was years after my psychosis, and instantly paranoid, instantly suspicious of others around me. So I stopped doing it. That was my official last time a year ago, but I took a 4-year gap and then smoked, and then another 1-year gap now. And I thought that was it. I thought that was a closed chapter and it was in my past. It was behind me. I can move on. Oh, little did I know it would come and bite me in the butt a couple months ago. And I didn't start smoking again, but I kind of questioned my mental health. I was like, you know what I'm kind of feeling off. What did happen to me during that one summer? What was that? I was like, what was I feeling? Like, was that caused by cannabis? Like, what did I go through? So I started looking into it, and cannabis-induced psychosis, and that's where I found these groups. But before I found the good stuff, I found all the bad stuff. And that was articles about prognosis for cannabis-induced psychosis and the outlook for patients who go through it. You know, even without a history of mental illness, 40% of people who go through an episode develop chronic illness and develop schizophrenia. And the fact that it can change the structure of your brain, the brain chemistry, if you smoke before you're 25, all this stuff. And so I started obsessively researching, like, how do I recover my brain? How do I bounce back? Is the damage already done? Is my IQ lowered for good? Is my brain doomed? And I was so obsessed with those thoughts and I didn't like the chance of becoming schizophrenic. I didn't like that 50% chance at all. So I actually had a suicide attempt on this last November. I was driving and I closed my eyes and I almost swerved into the median next to me, but then I kind of snapped out of it. I was like, what am I doing? But luckily, I'm right here. So I got pretty heavy into dabbing. School was a past responsibility for me. I completely just gave up on school. I somehow scraped by and graduated, and then came the summer of 2017. That was when I was free range to do whatever I want. So I dabbed and did all stupid things, would hotbox. So I'd lock myself in a car with my friend and we would smoke it up. So like you couldn't breathe in it besides marijuana. That's something really common. And, I would get high daily. I couldn't sleep without it. And then it took from one dab to feel something. So started taking 2 or 3 to feel the same effect. That standard tolerance building that you hear from. It wasn't, and this is when it started really becoming a problem because it got expensive. Because you get $30 for about a couple grams of shatter, and then you go through about a gram a day. It starts, you're spending hundreds of dollars a week. And of course, me and my friend stole money from my mom. We started selling our belongings. He started robbing from our friends, and we would do anything we could just to get high. And we were so oblivious to what we were doing. We still thought it was just weed. We could quit whenever we want. It's whatever. And all was good until I was sitting down on the couch. I just got done dabbing, and I hear my mom, and she yells my name at the top of her lungs. She goes, "Ethan," super loud. And none of my friends heard it. So I'm like, I get up and I'm like, oh, okay, let me go check that out. And they're all confused. And I run upstairs and she's asleep. So she never even called my name. So I was hearing her voice, and I didn't really think anything of it. I was like, well, that was odd. I could have sworn she just yelled my name, but didn't think anything of it. So I went back and smoked again. And this time I was hearing the sound of the crunching of food. So like cat food, that kind of crunching sound that they make when they eat, so oddly specific. But I was hearing that, and I had 4 cats, so I didn't think anything weird. It just kind of was like white noise. But then I look over to the food bowl, and there's no cats eating. And the sound of the food gets louder as I look at the food bowl, and it's like this crunching sound that encompasses my head. And I start kind of grabbing my head and like shaking and going crazy. And I told everybody, get out of my house, get out. They're like, what's going on? I'm like, I don't know, just get out. And at the time, my best friend Kari lived with me, and he was like, dude, you're just toking out, you're having a bad trip. So I stopped doing that, or I stopped for like a couple days for my head to clear up a little bit. And then things started to get bad again. Every time I smoked, I'd get paranoid. I'd get suspicious of Kari and about his intentions and about what he's doing. And that turns out some of those suspicions were correct, but we'll get to that. But I remember at the time, I didn't know what was going on, but I started getting obsessed with inanimate objects. I started thinking that this green towel that's hanging on my railing, that symbolizes something, and the universe is trying to tell me something. Why is this towel green? I have to get to the bottom of it. I have to figure out. So I was spending all of this whole day, then the next couple of days, like researching the color green, or getting obsessed with like, why is this towel green? And very bizarre fixations. And then went from a green towel to a white lighter, and it went from just random objects, and I would obsess over them, and I would pull my hair out trying to like figure out what they all meant and how they all connected to each other. And my friend at the time was like, well, you better get to the bottom of it. And I don't think he realized he was feeding my delusion there. So I got that really, because I was like, oh my gosh, he gets it. I got to figure it out before he does, kind of thing. And that was that. And that's not even the worst part. So I continued to go back to smoking weed, because I didn't put 2 and 2 together. I didn't realize that the weed was causing this, because it was happening while I was sober as well. So I thought, this is just odd, but it's not the weed. And I remember feeling a snap in my brain. Like it literally felt like something like it snapped. All of a sudden, my sanity was just altered. I started hearing voices, having conversations in my head. I was having conversations with family members and friends, and I was getting in arguments with them. I was fighting with them in my head and having full-blown conversations about random topics, and it was really bizarre. And at the time, my mom kind of brushed it off as anxiety, because she didn't know what was going on. I'm like, Mom, this is not anxiety. There's something going on with me. And I call that day D-Day, because that was kind of the turning point. That was when my psychosis officially begun. And the very next day I had to go to work, and I go in, and I worked at this factory assembly line just for a summer job, just to get some extra cash. And I'm starting to assemble these pieces, and I get these voices in my head like, you're doing it wrong, or stop doing that, you're messed. And it would just bombard me with these voices in my head, and I just could not focus on work. So I went up to my boss and I quit. I quit that day, and I was like, I can't work. I don't know what's going on with me. I can't work. I can't focus. And that basically began the most terrifying couple of months of my life. So I stopped smoking. That was the first thing. So that's what was interesting, because my psychosis didn't go away for like 2 months, even when I stopped smoking weed. The worst thing for me by far was mixing dreams with reality. So it's so hard to explain when you're in a stable mind, but basically I couldn't distinguish from what was real and what I just dreamt of. There'd be moments where I'd be hanging out with my friends. I'd be like, hey, remember when we did this? And they'd be like, what are you talking about? And it was then I realized it was a dream I had. And that happened quite a bit. And sometimes I thought the dreams meant something. I thought, I had this really bizarre one, because Kari was known for stealing stuff, stole my mom's cameras, stole all this stuff. And I'd have dreams of me finding it in particular drawers, and I'd run around the house opening those drawers when I woke up, and of course it's not there. But that was a theme of, because was thinking the universe was telling me things. And another thing, I was super paranoid and suspicious of other people. I was shopping at King Soopers, and the receipt was printing out, and the lady next to me was kind of looking at the receipt printing out, and I snatched it really quick. And then she kind of looked at me like, okay, but I thought if she took that receipt, she would have information about me. And I thought she would know, like if she took that receipt, she would know about me, whatever that meant. Like it was weird. And when I was driving home, I would always go in circles to make sure nobody was tailing me. And yeah, I lived like that for about 2 months, and it was the worst experience of my life. And to get out of it, I basically stayed abstinent, which was the main part, but I also took fish oil, started exercising, eating better. And I'm not saying it cured it, but for me, I like to think that it did help. I started seeing walk-in therapy because I knew something was wrong. That was one thing that distinguishes mine from a lot of cases, is I had a lot of insight. Like I had some delusions and I had some hallucinations, but I knew something was off the entire time. I was like, something's not right. I pretty much stayed abstinent for 5 years. I had a slip up about a year ago. I was kind of testing how my brain was doing. I know that sounds stupid, but I was like, if I smoke right now and I just have a good time and I feel fine, that means I've healed, right? That means that was my logic. I was like, that means I'm better. That means nothing. I'm not going to smoke all I want, but it was kind of just out of curiosity. So I just took a little joint, couple puffs, and instantly I got paranoid. I got super suspicious, even just off of marijuana, even just off of flower now. And that was years after my psychosis, and instantly paranoid, instantly suspicious of others around me. So I stopped doing it. That was my official last time a year ago, but I took a 4-year gap and then smoked, and then another 1-year gap now. And I thought that was it. I thought that was a closed chapter, and it was in my past. It was behind me. I can move on. Oh, little did I know it would come and bite me in the butt a couple months ago. And I didn't start smoking again, but I kind of questioned my mental health. I was like, you know what I'm kind of feeling off. What did happen to me during that one summer? What was that? I was like, what was I feeling? Like, was that caused by cannabis? Like, what did I go through? So I started looking into it, and cannabis-induced psychosis. And that's where I found these groups. But before I found the good stuff, I found all the bad stuff. And that was articles about prognosis for cannabis-induced psychosis and the outlook for patients who go through it. Even without a history of mental illness, 40% of people who go through an episode develop chronic illness and develop schizophrenia. and the fact that it can change the structure of your brain, the brain chemistry, if you smoke before you're 25, all this stuff. And so I started obsessively researching, like, how do I recover my brain? How do I bounce back? You know, is the damage already done? Is my IQ lowered for good? Is my brain doomed? And I was so obsessed with those thoughts and I didn't like the chance of becoming schizophrenic. I didn't like that 50% chance at all. So I actually had a suicide attempt on this last November. I was driving and I closed my eyes and I almost swerved into the median next to me, but then I kind of snapped out of it. I was like, what am I doing? But luckily, I'm right here. I think my story was an exception. I know afterwards I had that hospitalization, but that was more because of my own anxiety about the aftermath and if I'm going to get schizophrenia or if it's going to come back. But, I stayed abstinent and there's no reason for me to believe it's going to come back if I don't smoke. And I know there's still that risk, but I'm doing fine now. That's all you can do. You can thank the stars above that you're one of the lucky ones. And the fact that kids are going through this kind of breaks my heart, and it just makes you realize, like, recovery is possible. It is.